Yeah, there's usually a blood vessel right at the base of this. That's actually a systemic vessel, so very important to have good control so we don't, cause any bleeding. Let me have another snap and I'm gonna cut, okay? Do you have ties available?
I do not.
Okay.
Can you get some ties?
Alright, here we go. Alright, okay, I got it, okay? I'm gonna have you hold on to this while I tie. Whoops! Oh, there's a lot of bleeding. Wait, let me just have some pads. I'm gonna just put pressure on it. Alright, I gotta find it, okay. Yeah, there's just a little bleeding from that blood vessel. We're gonna be okay. Really? Okay, well there's no active bleeding. Okay, let me just take a quick look, okay? Alright, another snap, okay, couple of those, you have those ties ready? Alright, okay. Alright, section. Okay, I think we lost about 200 cc's. But, okay, I got it. Alright, I think we lost about 200, maybe 300 cc's from this. Can you hold on to this or we're gonna tie this, okay? Baby, okay? Okay, alright, the bleeding is controlled, suction. Alright. Oh, maybe there's more, maybe it's like 400, I don't know how much we lost, that's just a lot of blood, but no more. It's all cleaned up, okay. How's the baby doing?
Okay, blood pressure is low but stable right now.
Alright, good, okay, alright, let me just, do you need me to continue, want me to stop while you catch up? Can we make sure we have blood? I think I lost probably a unit in here, or two, and he started with a hemoglobin of 7 pre-op, so I think we're gonna be pretty low. Can we catch up, just have blood come?
Okay.
Sean, can you check his blood with me?
Yes, we can check.
Alright.
Okay? Good blood? Good check?
Yeah.
Alright.
At the blood bank, can you
Alright,
have
well,
they have a
is that the real blood pressure? 60/29? Alright. If the blood's not here, can we at least give some colloid?
Can we
Yeah,
get
I
an
like
anesthesia
that.
tech?
We got
Can you
blood.
Hey Carol, call an anesthesia tech to come help.
I'm already on it.
Get Dave in here.
Alright.
Or Lori.
Siegfried's here.
Okay. Well, I don't have anything more active, but he lost. Yeah, he lost quite a bit. We're gonna have to catch up.
Okay.
Alright, because he started very low.
Anesthesia tech's on the way.
Okay. Is blood here?
Alright.
Sean's getting it.
Okay.
Well, let me have the staple. I'm just gonna take this Michael's out since he's stable. Alright. Alright, here's the specimen. Alright, it was a little oozing from there, a little congested. Oh no, I think I knocked a little pot off. Here, let me just have Bobby. Sorry, I have a little bit more bleeding.
Okay.
Alright, okay.
Oh, okay.
Alright, sorry, I think I lost another maybe 100. So it's all good now. It's all stable now. Nothing bleeding anymore.
Blood's here.
Okay, so let's see his blood.
Yeah, we may have lost a couple units. Alright.
Just stand by it. Okay, just not
Alright.
getting all.
So I've got
It's
PRBCs, I've got platelets,
PRBC.
I've got FFP. What would you guys like?
Let's start with PRBC.
Yeah?
And we have enough access.
Sean, I checked his blood.
Okay. The blood is coming in right now.
You want me to get some dressings? What kind of dressings do you want?
Oh,
Just 4x4s or?
yeah, just for my pocket.
Okay, so let's couple codes.
What happened? I'm already done.
CO2.
Okay,
There's
well,
no blood pressure.
okay, the
Blood
blood,
chest compression.
Okay.
Giving a PA.
Alright, so I'm sure he's low on volume. We
Okay,
lost
so
probably
let's
2
give him
units
blood.
and he's very low. We just need to get blood in, okay? Who's gonna come and, I'm gonna start CPR, we're close.
Starting CPR.
Okay, so who's gonna come and
43.
I just blood work too.
Cause I'm kinda tired, I didn't have breakfast.
Got that?
Alright.
Drill. OR2. Make sure you say
Okay,
drill.
can we send for some labs?
Okay, thank you.
Alright. Who's up? Can we have some people lining up here?
I'm ready.
Okay. Alright, here you go. 1, 2, 3. what? Okay, we're gonna do all
Yeah,
of
you want me
it.
to help with you?
Alright.
Yeah, we help along.
I think we're gonna need another, why don't we bring another unit in?
Yeah, we have, other
Yeah.
key
Good, good.
Okay, I'll call the blood
Okay,
bank.
so this is second unit of,
Yeah, but she, I don't know if they're prescribed it.
You give her a good check, maybe.
That it? That's all we get?
That's all we get.
Anyone lining up to relieve, Gail?
We have to be sure.
We're doing 2
alright,
minutes.
so today we're not.
Okay.
Okay. Ready?
Okay.
Oh, okay.
Now we don't have CO2 on the screen. We should have some CO2.
Here, Andrew. I'll have you do that.
Right, Joe.
Oh,
Up here with,
8,
Carol.
9, 10. Okay, so we got 10 max cell epinephrine.
Okay.
Completely.
20 kilogram patient.
It's got 0.2 milligram epinephrine. Should be working. I see the screen not working. It's not pushing hard. But we should be able to see some CO2. When we get a effective CPR.
So we're not seeing any CO2 because something's not connected, or?
I don't think it comes up on that screen, actually.
6-year-old now. Oh, 6-year-old.
0.2 milligrams epinephrine.
Okay.
Given.
Okay, got it.
Can we check pulse?
Francisco,
yes.
here, relieve Gail, or, Dave.
Dave.
Continuous CPR.
Yeah.
You can switch person.
You can be behind Julie.
Push a little harder, Dave.
So I have a blood
That's
gap.
good, perfect.
Get in line.
I have a blood gap.
Okay,
So
You
we
wanna
got
be,
two
you wanna be the CPR code?
Dave, how are you doing on CPR?
As far
No,
as
we
my
switch
prompting.
out.
Want to switch
When
out?
to switch, yeah.
Yeah.
Okay.
That's
You need to switch out?
What do you wanna, what labs do you wanna order?
Just sample everything.
Okay.
Just an, okay.
Yeah.
Would you run an ice bag?
No, we need you guys to be, stand outside in the sub-sterile.
So you have to
We'll call you when we need you.
That's fine.
How long before that says that we want
Okay, so if it's urinous, you can give us a little epinephrine. Would I be a
Dave and Jimmy, you guys can step out.
Aw.
So it's not urinous, let's give another little
What does we
They're getting changed.
So you need to push a little deeper. A little more.
Okay, stop.
Good.
1 minute.
Hi,
Hurry.
You wanna do med prep?
0.2.
Huh? No, you haven't
But
seen
each of
here.
those is,
Are we actually drying?
Andrew has some.
Oh, okay. Are you?
I'm the
Med prep.
you are?
Yeah.
Alright, is this hospitalist?
Yes.
Yeah, we already still CPR.
How much blood have we given so far?
We give 2 units of blood.
2 units, okay. That should catch them up. And,
Yeah, we gave, so I can prep it and I'll hand it to you, right?
Yeah, that'd be good.
Can I relieve you in
Yes,
CPR?
absolutely, prep it.
Just 0.2, okay.
Alright.
Okay.
That's what it's for.
0.2, prep for you to give.
Awesome.
Oh, we have a
Yes,
4-year-old, with bleeding necro came in with hemoglobin of 7. We found the necro, took it out, but we had some bleeding during the surgery, probably lost maybe 400 cc's, and then, when we finished it, but then he, just kind of lost pulse. So we've been giving blood and. You got 2 units of Paxil.
Got 2 doses of epinephrine. we have the jaw pad on. So that is still EPA. So we have to defibrillate.
When was the last app you gave them?
Last time that is so.
2 minutes ago.
Alright, so we should probably use another one. Can we check pulse, please?
Check pulse.
Did you give us okay? You sure? Okay, just continue chest compressions, give a second. Happy?
You nurse.
Right. We have a blood gas and
Okay. For your RT? Yeah, there's an RT.
Yes.
Probably have the PCU nurse take over with the med.
So-
But you'll still do med.
where is that? I don't see it too.
Step out.
Point two.
Andrew, she's gonna take over for the red, so you can
Oh.
step out.
Okay.
Just put it on the thing. You can put it over there.
Somebody,
Ready? 30 seconds. Okay.
You want the RT one?
Are we still
And then you
bleeding?
can coach that.
Are we still bleeding yet or?
No, the bleeding's controlled.
Strap is good. Rate is good.
Okay.
Who's next in line for
Final
CPR?
CO2 would be over there.
Who's next in line for CPR?
Can we give some fluid?
Sure, you just got that.
Do we have somebody else to do CPR?
That's just for you. I don't know how much
Nash
is
is
it.
next.
Nash is going to take over for CPR.
In 1 minute.
So somebody is recording, right?
Yep,
Yeah,
I got everything.
Still good, ready, still good.
Can we get the blood gas and
Yeah, I'm getting tired. I'll trade out. Okay, Nash, step up.
Rotate up.
so how much blood we give so far? Sorry.
2 minutes.
2 minutes. And this kid's how many kilo? 10 kilos.
Anybody else out there for CPR?
A little deeper and a little slower.
Yeah.
A little faster.
If we can get the blood gas with the hemoglobin and hematocrit
Yeah, she can run an ISAT.
quickly.
So a minute.
So the blood gas probably go and then you can just get a 7.0, 40, 65, 14, 90,
A lot of stress.
negative 15. Lactate is 12,
Good.
HMH is 5 and 15.
Okay, so
ICAL is 0.8.
so hemoglobin is still low. Let's give another blood. And let's correct the metabolic acidosis we give a bicarb.
How much bicarb?
You have
I
1
give
minute
it 1
now.
kilo. So
Okay.
let's
I
check
can
pulse
rotate- I can rotate.
and make sure that the second epi pending. The third epi pending.
Epi ready to go?
Yes, please. And bicarb.
Okay, here's Epi ready to go.
And blood, another blood. Great, it's only blood.
We have another unit hanging.
Thank you. Are we running it fast?
Running fast.
Okay.
Epi in 0.2 milligrams.
Okay. And the bicarb, please.
And bicarb is.
1 milliliter per kilo. So 10 max.
So we'll have very little pressure. So we check pulse. Yeah.
I feel pulse.
Okay.
And now we have that pedal, so we're gonna be.
All right. So hold the let's cycle the blood pressure.
Hold it just.
Yeah. Hold the compression in your pulse. Cycle blood pressure. And get ready to give another fluid dose if you need it to.
So
But they didn't say where.
I know, I tried to ask you.
Is that the blood pressure?
Yeah, it's one okay, Julie, you wanna step up the compression?
Okay.
We're holding you for.
Yeah, wait, are we holding? We're holding. We have a
Yeah, we hold it. We have
I know.
We have a
Oh,
pulse.
yeah.
20 mils, 20 milliequivalents. Ian.
Yeah, I feel the pulse, so pulse is very
No,
strong.
we already have
Blood
one.
pressure, let's hold up on that.
Working
Okay?
on that.
Okay, thanks.
That's okay, thank you.
Okay.
Okay.
All right,
We're gonna stop.
let's
All
stop
right.
here. Anybody who just came in lately, who didn't have a role, can just step outside so we don't have so many people. And then whoever wants to stay for the debriefing can. And,
Professional for sure.
okay. Okay, so I need somebody to give us a 10-word or less summary of what happened. And that probably is somebody who's here rather earlier in the time than lately. So, anybody?
Well, we called the code when we saw desaturation.
Okay.
It took a while for people to get here
Okay.
and supplies.
Okay. So, so for the people who came in late, did they hear what was going on when you guys came in? Was it told to you this is a 6-year-old with fill in the blank? So that's what I'm trying to get. So, did you want to tell us this is a 6-year-old who has, so this was a 6-year-old who underwent surgery by Dr. Sue and had hemorrhagic shock, who was in shock, okay? And that is the mindset that we should have thought of when we were coming in here. A child is bleeding and needs compressions and volume to reverse his shock. How did it overall feel? Is anybody terrified? Are they excited? Are they, oh my God?
I think it felt actually less chaotic than when we actually did.
Okay,
not
great.
too long ago.
All right, perfect.
It was
All right.
quieter.
Yeah, I definitely thought that the volume of everybody's voices was nice and low, and you were able to hear people asking other people for their roles and, you know, good direction. How about let's start with the things that we felt everybody did well. So, was there anything outstanding that you were like, yeah, this really went well?
I think Carol and Susanna were communicating pretty well. About, I got it kind of stuff.
It's
So.
helpful when I feel the most helpful is when the pediatric hospitalists come in, because they really direct
Yeah.
what's happening as far as
Yeah.
specific to the patient with meds and stuff.
Yeah,
That's very helpful.
Yeah, and I heard Ray identify himself when he came in and said, I'm the pediatric hospitalist, what's going on? Carol, I absolutely heard you putting people out in the ante-room when they weren't needed and directing traffic and also giving people roles. I thought that was excellent. That's very important because there's 20 of us in the room and not all 20 are needed. Probably only 5 people are needed, but you need people in the background to take over CPR, to be running, to call for phone, you know, to call for stuff. All right. Ozzy, you want to jump in?
Yeah. So it was interesting. Mistakenly, we weren't able to have all the beeping.
Oh.
So it was quiet, and in a way maybe helpful, maybe not as jarring, kind of anxiety provoking, but yes, it did require everyone to like really stare at the monitor. So in the future we would have all that beeping going on. I will mention something about the CPR part. So according to the American Heart Association, time to chest, does anyone know how fast we're supposed to get on the chest from the time we find a patient pulseless? Immediate, within a minute. So you guys agree with that? Pads should be on, this is not AHA, but the recommendation is pads should be on within 2 minutes. You guys agree with
Yeah,
that?
Carol, that was really
Epi within 5 minutes. It was within 2 minutes, so that was great. I didn't hear a pulse check in the beginning. Before we started compressions.
Oh, I didn't hear that.
Was a pulse checked?
Not in the beginning.
Not in the beginning. Any reason that wasn't triggered for the people that were here?
That should be led by the anesthesiologist, is that first?
It could be.
That's probably what we need to
So,
define.
So that should be sort of the really, when we start, when we stop, it should be based on a pulse, right? But I will say we have lots of monitoring, so if there's no art line, there's only no pulse, right? So that's something you could go by, but ideally we'd like to take a
Because if we don't see CO2, we know the patient has no pulse.
Right.
There's no point to check pulse, right? Because it's not chest compression. Because you don't want to delay chest compression, right?
Yes, so you don't wanna go fishing around for a pulse, so that's legit, but in general, you know, you don't always, in the OR you might have a line, sometimes you don't. So don't forget the pulse, and the rhythm we had was PEA. It was, you had sinus activity, but, it actually was not a perfusing rhythm, so it was pulseless electrical activity. So the fact that the other numbers disappear tells you there isn't perfusion, so that would be a trigger to check a pulse or just start compressions if the A line is out and there is bleeding, like something is going on. The scenario was supposed to be a bleeding patient that goes into PEA, but have you guys used a massive transfusion protocol?
Yes.
Yeah.
Yeah. So do you know what do you know about the protocol or yeah?
Well, somebody has to activate it, it's usually the anesthesiologist.
Okay.
When they feel they need more and constantly coming, and then we don't stop until they tell us.
Okay. So you don't stop what? Getting the blood?
MTP, yeah.
Okay, so you just get more cooler.
The SSA just keeps running until they tell us to stop.
Okay, perfect. What is in the cooler? You guys know.
FFP,
We have it on the-
platelet.
Yeah,
Cell,
one platelet, 3 RBCs and 3 FFPs in the first round.
Okay.
Yeah.
I know this is a little bit of a fake scenario, but in real life, what would you have given a patient that's bleeding? You gave 2 units of blood first, right? What would you have normally given next? So I couldn't say we should do an actively bleeding case in the future. We didn't do enough moulage, but if the patient is, you can't control the bleeding, you would have done another product after.
FFP.
Yeah, you might have FFP, or you might have platelets in there, right? So MTP, you probably finish what's in the cooler, right, before going to another pack cell. I mean, your call, but. So if a patient is still bleeding, please think that you're low on your other factors, right? So that was sort of the idea, but we weren't able to really fully simulate that.
But if platelet comes in the first round, they're gonna get it. Platelets do come in the first round.
They should be the
So
cooler.
Yeah.
we would
They're
give
in
it.
here.
We would give
I
it.
don't think there's cryo, but the platelets and
Yeah,
FFP
we
should
would
be
give
in
it,
there.
they just have to ask. So.
And do you give it, or does the anesthesiologist?
Anesthesia does all that.
Okay, and I think you guys have become familiar with the rapid infuser, right?
Oh, we have.
You have?
Yeah.
Okay, great. So I know maybe normally the anesthesiologist would take care of that, but I know you have some knowledge of it. This is a relatively bigger patient, but in babies, there has to be a clear understanding of how much you're giving, right? It's not gonna be a unit of blood, right? So someone may actively be pushing it or putting a pressure back on it, or some other method that you would have to help out for. Anything
I
else?
think those are the things we don't know.
I don't know.
The OR staff, we don't have that knowledge base.
I know. So we're hoping to review this stuff. And in a patient that's coagulopathic, right, you're bleeding, we're giving you product, but ultimately your coagulation factors are deranged. So if a patient is coagulopathic, it's a pediatric patient, and obviously coding. What's important in a pediatric patient in the OR?
Warm. Warm?
Yeah, you have to keep them warm, right? So what would you normally do to make sure the room stays warm?
We increase temperature in the room. Always.
And do you usually have
With
a
warmer
some
blanket.
kind of
Warm blanket on them.
blanket? Okay. I know this patient would be exposed, so at risk anyways, but just to be aware of it. Would you have a temp probe normally in a patient?
Yes, yeah, anesthesia would.
I think those are my main medical points. Anything else about the medical part?
What's the maximum time that you could stop compressions when doing compressions on a patient?
Yeah, 10 seconds.
Yeah.
Yes, 10 seconds. Yeah.
So Ray is the hospital hospitalist is monitoring the Zool, there is an idle time on there, so we would know exactly how much time we've been off the chest. And the depth of chest compressions in a child, 2 inches, 1.5 inches for infant, so that should show that.
Yeah.
And the compression rate,
At least 100.
At least 100.
100 to 120, so
Yeah.
there is a cap, so we don't want to get overzealous about it. And what about the respiratory rate? Patient with an airway. What would our anesthesiologist set the vent rate to? Anyone remember? What is that?
12 to 20.
So it's actually 8 to 10 during compressions. So normally we would bag at 8 to 10, but you probably just set the rate, set the vent up. That's okay too. So the point is you don't want too much chest intrathoracic pressure. You want the heart to be able to fill and compress as much as possible during a pulseless state.
Do we have a backboard under him?
No, that's the one thing we forgot.
Okay, so that would have helped. Do we have a backboard here?
On the back of that.
So yeah, until the crash cart came in. Okay, good. But Carol, I liked how quickly you flipped him over, you put the leads on him. That was excellent, yeah. Yeah, and I like the closed loop communication between asking for medication or asking for blood and person saying blood being given, epi being given, bicarb being given. How much bicarb do you need? That was very good.
I heard that, yeah.
Yeah. At the beginning, when his blood pressure was drifting a little bit, is Wendy still here? Dr. Sue, how did you feel the communication was at the very beginning with your anesthesiologist? Were you guys on the same page? Did you feel that you were communicating clearly?
Oh, I thought so. I think
Okay.
up till the code was all very good.
Okay,
Yeah, even
excellent.
afterwards I asked, how much blood has been given. and
Super.
I think there's being.
That's excellent. Yeah, yeah. Because you two have to be in like that, talking about the patient. Yeah, it's hard. It was weird without
You should
the-
also ask our anesthesiologist how she felt, because usually
That's true.
they are
So,
more communicative than
so
surgeons.
did you
Surgeons
find
tend to not
that's
say.
actually a great point. So how did you feel coming to this pediatric code? How did you feel the communication was, and when Booty came in and asked to take it, how did you feel that went?
I think it's good. Only the health team is coming Tuesday, right? So we keep compressing it. Okay, so.
Okay. All right. Very good. Very good.
So the Zoll doesn't really tell you much about recoil, so just a reminder, just allow the chest to recoil before
Mhm.
you.
Yeah, so compressions hard and fast. That's a baby shark theme. All right. Not staying alive. It used to be staying alive. Now baby shark is the new thing. A third of the AP diameter of the chest. Allow for full recoil, so the full amount of blood. Get the backboard underneath it and change out every 2 minutes. And that is one roll for one person. That's somebody. That's one full job. Another full job is the meds. Another full job is the runner. Another full job is the crowd control. Another full job is airway. And then leading the code is another full job, yeah. And then if anybody has things to contribute, they can certainly say, I see this happening. I feel this needs to be done. I'm worried about how this kid looks. Oh my gosh, I think we need a bear hugger to warm him up. Can I go and get that? Because it's very hard to be concentrating on one role, but to have lots of people. It's hard to do one role and stand at the bottom of the bed. You need people to feed you information.
And Ray, for your role, so your role is the Zool, and I noticed a lot of people are there. Were you able to see? Did you feel like I need to pick that up and put it here?
No, I could see it from there.
Okay.
So normally, Tyrese, was the med tray still in there? You used it there? The med tray? No, sorry.
No, in the top drawer, it's still there.
You use that? Okay, so normally what would happen is,
Oh,
they would take the tray out and go to their own space. If anyone needs anything from the drawers below, they can get them. And then, so not everybody has to be like right there on the cart. And if you need the Zoll, like
Put it right here.
in front of you, then they put
I had a question. Could we move this out of the way? I just noticed that when they were doing compressions, you know, people would step aside and it stopped the compressions. And the way I was taught is that when you're doing compressions, you should be ready, and then as soon as they tap, the next person steps up and is doing, and there's no stop. So I was wondering if there was a way that we can, if there was enough room to put another step stool here, so that then they would
Yeah.
go on
Absolutely, so that
either
would mean
side.
putting the Zoll at the base of the
Right.
bed and then moving the crash cart back.
Okay.
But once you've taken out the tray, you don't need that anymore.
Right,
So that would be
push it
one
off.
thing, yeah, that,
Okay.
yep.
There was a wire that was sometimes shipping us over.
I know.
So those are all the little things when you do your codes enough time, you think of, oh my gosh, let me put 2 stools on each side,
Yeah.
move the cart out of the way, put the Zoll on the bed, put up the volume on the monitor, turn up the temperature in the room. That'll come easy to you guys.
So I have a question. I know within the OR, whenever there's a code, they try to, deal with it. They don't follow code blue normally, right?
For pediatrics, we do.
Oh, for pediatrics. So then a pharmacist would come and
Yes,
assist with
but
that.
we told them not to come.
Okay,
this time.
gotcha. But normally they would?
Yes.
Okay, all right.
And also who would be here is a lift team. Does the lift team come to the OR?
No.
No, not
Okay.
usually.
Okay, so
The
that,
scrub techs, the surgical techs.
okay, so
Yeah.
yeah, so that's important, getting our CPR.
And we have our SSAs as well.
Yep, so then CPR is key. CPR will keep your kid alive.
Well, we have,
so-
Lisa's wanted everyone to practice drawing up mats, and really, pharmacy's gonna take a bit. Like today, there were no buddy suits. I don't know how long people would have waited around to,
And the
If
thing
it's a
is that
code,
a
you
lot
don't
of
have
times
to.
Kathy would come
Oh,
and
that's
help,
fine.
and Kathy is not wearing
You don't
their
have to
scrub.
wear it, just
Kathy's
come
wearing
in.
their own scrubs, so a lot of packing nurses have their own scrubs where they have
Right.
money on them.
Yeah, I'm sorry, you're right. If it was real, people should have just been able to come in.
Right.
But anyways, there might be a
Yeah.
delay of sorts,
Yeah.
so.
But
that's-
even you guys, it only took 5 minutes and 39 seconds for you guys to get here, because I was timing. So, as soon as they came in, I was like, okay.
But the first epi would have already been given.
Right.
Somebody would have already drawn that.
But I like how you came in and said, I'm blah, 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 what can I do? Booty, you said it. I'm the PICU, what can I do? What can I do? I'm Dr. Mohana, what can I do? Because you never know what role that person.
I think I said I'll take over chest compressions.
Okay, well, I think I heard I'm Dr.
Yeah.
Okay.
I just have one question. I'm Lynn, I'm from the emergency department. I've been up there on the below the code recently. I hope you didn't mind that I stepped in.
Oh, no, thank you.
So the blood is weight-based for the kids, right? So when we look at this, and as this last case, is it MTP, so when you say 1 unit of packed cells, that's 10 per kilo, or are we going up to 20 per kilo?
So, I
20
think
per
we
kilo.
didn't give you full information. This was gonna be a 20-kilo patient. Normally, we give 10 to 15 mLs per kilo. So
Okay.
that would have been okay for a unit for his
Okay,
weight.
so that's kind of what we think about
But
as a unit.
please do
Okay,
think
thanks.
weight-based, and if you can get a unit or more, if the volume is less than a unit, you want to give less than a unit.
So when we call the blood bank and we say MTP, just a thought, I don't think we do this. They wouldn't want to know the weight so they could prepare the volumes. No, huh? They're just giving us adult units.
In the emergency, I would just get the whole unit. It's our job to, that's why I asked, like, how many units has been given, so I can
Right.
calculate my
So we
brain.
bolus this kid up to 40 per kilo when we were on pack cells, but then do the platelets go the same way, and then does the FFP go the
So
same
those
way?
are, for P's, that's all weight-based, but
Okay.
they'll give you a unit.
Okay.
So you would have to figure out.
Yeah, we were drawing up and pushing without a filter. That was my other question.
Here,
Yeah,
Right.
so when we are giving these, are we supposed to draw with a filter somewhere in the line? Just questions I have about blood.
Well, that's different because the ER, you're giving it, and the OR, they're giving it.
And we all came up here,
So how would you-
Yeah, so our anesthesia is dictating the amounts.
use a filter?
Okay.
I think usually I feel like we want to have filter, or maybe we can just get in the bag, and
Yeah.
in the trauma situation,
Yeah,
you don't
it's
have.
okay.
And you definitely, we prefer to have a normal blood transfusion, because you don't want to give cold blood to
Right.
a patient in arrest. So you want to make sure that the blood is warm,
Yeah.
which is, especially when you're giving high volume, which is super, super important.
That's why you brought up, yeah.
All right. So is there anything else for the debrief? Are there any more questions, any concerns?
One more thing, I've learned that the code cards have PPE bags. So I think in the OR, usually you wear N95s. Is that the case?
No.
For certain, only for certain things, like if they're positive
So my
or.
understanding is the hospital has said that if there's a code, you have to grab an N95 and you probably already have an eye shield. But that is part of codes now. So we did add our bag, but I'm sure it's not, well, seen very well. But do keep that in mind.
That's the first time I'm hearing that, so.
Yeah, last week
When
was
did
the
that
first
happen?
time I heard it.
Do you know the rationale for that?
So, I mean, you have a closed circuit because your patient is intubated, unless there's an exception for OR. Basically, either our patients aren't tested, or they weren't immediately tested.
Yeah, if
So
they are tested,
typically-
you do wear an N95.
And why didn't we start this 5 months ago? I don't know. But now we're doing it. Okay, that's all I wanted.
All right.
No, that's it.
Good job, everybody.
All right, well done.
Thank you.